Thank you so much, Dr. Leo. We appreciate your contribution. We will go straight to our next presenter. Dr. Obiwane, please introduce our next presenter.
I am introducing our next presenter will be Dr. Mukhtar Mohammed. Dr. Mukhtar is a National Incident Manager and a member of the Presidential Steering Committee on COVID-19. And he will speak on where Nigeria is currently in its preparation for another pandemic. Welcome, Dr. Mohammed. You have the floor now.
Good afternoon, good morning, everyone. Thank you, Ngozi, for the generous introduction. Dr. Rudolf, thank you for the invitation. Colleagues, I'm glad to again meet with my predecessor, the National Coordinator, Dr. Sani, who has put immense effort and sacrifice in the setting of the Presidential Task Force and all the achievement that the committee has made in the last 2 years. So I think he has laid very much the ground about where been, how it started, what efforts have been made. And that really makes it easy for me to discuss about where we are now and what we need to do to prevent further pandemics in the country. COVID-19 has actually galvanized the international community, all countries, to come together to realize that we have to work together to fight the pandemic. Having COVID-19 in one place does not make another place safe. So we really have to put efforts to make sure that there is this international collaboration. So Nigeria has keyed into many of these efforts that are going on regionally in West Africa, in the African continent, and also globally. And generally, there are discussions between the general similar agencies about strategies, next steps, and what needs to happen in terms of epidemic preparedness, in terms of getting the vaccines to the arms, in terms of logistics, using testing technologies, and so on and so forth. That's on the global scale. For us in Nigeria here, we are concentrating on doing the little things that will reduce the impact or prepare us better when we have another epidemic or the next pandemic. We do not clearly know what form that pandemic is going to take. And therefore, you cannot say that you are 100% ready and you have everything in place. But at least based on the experience we had from Ebola, COVID, Lassa fever that have been going on, and now we have monkeypox, at least we have a direction about what needs to happen. I think Dr. Sani has spoken very well about the capacity building. That has been intensified. I'm proud to say now that many epidemiologists have been trained in all the states of the Federation, not only clinical epidemiologists, but also other cadres of health workers have been trained in various aspects and the roles they can play in terms of epidemic preparedness and control. In terms of clinical care, I think the PTF really saw the seed where we saw a lot of activities going on in terms of building intensive care units, supporting capacity for isolation, and also even putting dedicated funds. The PTF or the Presidential Steering Committee has dedicated some funds that were meant for all the teaching hospitals in all the state federation for increasing their capacity in terms of intensive care as well as building isolation facility. We've also provided funds, in terms of, like Sani mentioned, building the molecular laboratories and also looking at the epicenters. Lagos and Abuja have been prioritized, or also the procurement and distribution, that will make people safe. The NCDC, the enabling law that has established the NCDC has also been strengthened because we realized that there were some gaps very early on with COVID pandemic regarding quarantine and the powers that the agency would have. So all these issues have now been sorted out in collaboration with the National Assembly, such that if there is an epidemic or there is cause to take action, the NCDC or the public health officials will now have unhindered access, to the property and also be able to interject and also, take the necessary actions that are required. In terms of the public health approach, the Nigeria, what we call the Field Epidemiology and Laboratory Training Program has been intensified. Now we have over 1,000 graduates and people that are still going on in training. This is specialized training for epidemic intelligence. It is targeted at looking at these kind of unusual epidemics or pandemics that have the tendency to propagate and also have very high case fatality. The program has now been assimilated by the Nigeria Centers for Disease Control. Initially, it was supported by USCDC, but now we have internalized it. And the Nigeria Centers for Disease Control has taken the responsibility to continue to train and churn out, these capacities across the country. In addition to this, we have realized even before the COVID-19 pandemic that one of the weak points of the Nigeria health system was data collection. So a lot of resources have now been put in terms of collecting data. We have improvement in what we call the IDSR, which is the surveillance system of reporting diseases from the wards, from the villages to the local government, to the state, and also to the center. We have strengthened the coordination between the epidemiologists so that all the states and the NCDC and Federal Ministry of Health meet periodically, at least twice in a month, to discuss current issues. Like currently they discuss issues of monkeypox, the number of cases that are going on, what actions have been taken, and what are the likely areas that may be affected. So I think let me just also pause here because I'm sure there will be maybe some additional questions. But the bottom line is that yes, we won't say we are perfectly ready, but certainly we are intensifying and strengthening on the efforts that have been done before, and we are collaborating both regionally at the continent level and also internationally, because fighting pandemics cannot be done just in one place. We really have to work together to set up the systems and the methods to fight these pandemics. Thank you.
Thank you, Dr. Mohammed, for this awesome delivery. We'll now want to bring on Professor Nwosu. I am very sure that many of us will have questions for you, Dr. Mohammed, and we'll get to that very soon. So it's my honor to introduce the next speaker, and he is Professor Benjamin Nwosu. He is the Chief Endocrinologist at the Cohen Children's Medical Center, New York, and a Professor of Pediatrics at the Zucker School of Medicine. Professor Nwosu will speak on the role of the teaching hospitals in preparing a nation for medical emergencies. Professor Nwosu, it's now your turn. Welcome.
Thank you, everyone. Thank you for the introduction. Thank you, the host, for inviting me and the audience. Before I start, I want to say that I will take the position of the Nigerian youth. I'm not a government official. I'm not being paid for my participation in this session. So here is how I will start. We have to set the Nigerian COVID pandemic in perspective compared to US, Europe, Brazil, India. COVID-19 did not really touch Nigeria. Okay, so that's the context. And number two, is Nigeria ready for the next pandemic? I can absolutely say Nigeria is not ready for the next pandemic. And here are the reasons. One, Nigeria does not have the funds to actually address a pandemic. Nigeria is going to go bankrupt before the end of this year, for those who wish to know. There is no structural alignment of the healthcare facilities in Nigeria. The teaching hospitals are supposed to be the flagship centers where people will go for last resort. I was in Nigeria in 2021, and people were dying in teaching hospitals just because they have manifested the symptoms that might be suggestive of COVID-19, not that they have been confirmed as cases. So once they show symptoms, the healthcare providers will abscond. There is no national will to take on a pandemic in Nigeria, as far as I'm concerned. Like I said, I was there in 2021 to renew my passport, and people were fighting to get in line, at the center. Nobody was wearing masks and so on. So I was so afraid that I could even contract this virus. Then you think, I gave a lecture on Nigeria's Millennial Developmental Goals in 2021, and whether Nigeria met the stipulations or not, and Nigeria did not. I mean, the only thing Nigeria had to show was the NCDC, okay? So we give them a high mark for that. But the integration of rural health provision and then secondary health care services with the tertiary care services, which the teaching hospitals are set up to do, is completely lacking. You cannot refer a patient from a primary care center in Nigeria to a teaching hospital easily, okay? And when you get into the teaching hospitals, there's a huge issue of conflict of interest. Most of the consultants have parallel medical clinics where patients are being diverted to. Okay, it is the federal government has looked away from this issue for too long. People die because they don't have the money to pay for services at the teaching hospitals that are receiving money from the federal government. You have ministers and other governmental officials who never visit teaching hospitals in Nigeria. You have federal government officials who have doctors overseas. We know this because we are here, okay? Not a joke, we can give names. And so they don't care about the hospitals in Nigeria, because if they use the hospitals in Nigeria, they will see that they are derelict. Okay. People talked of, oh, we are going to build capacity. Well, what does it mean to build capacity? Why didn't you build capacity as part of your millennial developmental goal? People talk about we're going to take little steps. Why are you taking little steps? Nigeria says the giant of Africa. Can't you take bold steps? People talk about data collection, but how many publications have come out of Nigeria on COVID-19? Isn't it interesting that COVID-19, for whatever reason, blew through Africa, except for South Africa. COVID-19 basically blew through most of the African regions. And so isn't it important to do a study to find out what is unique about Africans regarding COVID-19? I hope there are papers, so I hope I'm wrong here. Now, were the COVID-19 test kits free to the people? I know I had to pay thousands to do my test in Nigeria, so I want to know whether the villagers were getting these tests free of charge. Now, there were 131 treatment centers in Nigeria. Can we please tell us what states these centers were in? And were they concentrated in Lagos and Abuja only? And that takes me to the next comment. Why prioritize Lagos and Abuja? Is it because the rich people live there? what of the villages? If you cannot strengthen primary care, then you cannot go far. So let me conclude by saying that Nigeria is not ready for any meaningful pandemic effort. And I'll take questions later on down the road. Thank you.
All right, thank you so much, Professor Nwosu, for that presentation. We are going to have one more panelist talk, and then we take questions from the audience and then continue the conversation. So it's my honor to introduce Dr. John Ndibe. Dr. Ndibe is a retired director of the Medical Services, Anambra State. He's currently a consultant for USAID-funded KNCV Global Vax Project in Anambra State. He will speak on how states can coordinate with the federal government and the role of Dr. Ndibe, welcome to the show.
Thank you, Rudolf, and for the invitation. And also, I greet all the panelists and our listeners. I want to start by saying that in Nigeria, basically, Nigeria has some structural problems in terms of its, in fact, across all its health intervention. Nigeria is a situation where we have a kind of misfit between where the problem is and where the resources are. It's an issue of an imparted, where resources are more at the federal level, problems of the health sector are. And so you find a situation where, even though it's the PSCs, the general hospitals that you expect to have most of the patients or solve most of the health problems, you find that that is the level where resources is least. And then at the federal level, where they should be doing more of policy and guidance, you find a lot of resources there. And so that's a situation of where the needs are, the base of the needs is down, but the base of the resources is up. And this is a kind of misfit. This makes it imperative that most of the states, to a large extent, depend on the federal government when it comes to health issues, especially in pandemics like COVID that require a lot of resources to control. Even in terms of human resources, you find that the most knowledgeable people are at the federal level. So whenever there is a problem or a health issue or a pandemic in the state or the local government, you find that people need to come from Abuja to come and assist to address these issues. So it's not different with the COVID. So when COVID came, actually, a lot of what states did had to depend on assistance and directive from the federal government. And that is the relationship that has always existed in most of the health interventions that we have. Now, when COVID came, actually, the intervention actually started at the federal level. But I must give it to the fact that the Presidential Task Force actually helped to mobilize a lot of resources, which ordinarily would not have been available to the states. And they assisted the states in establishing testing centers, providing PPEs, and even some were needed when the pandemic soon, because that structure, that resources are where the problems are still exist. And trainings that the lower centers, lower levels have are still things that are supported mainly by the federal government. So that also happened in the COVID pandemic, and I think it continues to happen now. However, I must admit that a lot of progress was done. There was a lot of support actually from the federal government, the Presidential Task Force, the NCDC, the WHO, and some other partners who actually supported the state to be able to establish some structures the emergency operation centers in most states were strengthened. Rapid response teams in the states were also established and strengthened by resources from the higher centers and from some of these NGOs and implementing partners. In Anambra State specifically, I know some centers were actually taken up by private organizations. For instance, at Umueri General Hospital, Access Bank, when I was just leaving the service, actually built and refurbished the center and equipped it with a lot of COVID materials required to respirators, beds, and all that, basically all that was there. And it was quite massive. And a few other centers also benefit from that. So basically, I would say that going forward and in the foreseeable future, states will continue to depend on federal government and the private sector. And if that be the case, it means that we need to actually have a plan that is well prepared to be able to harness those resources whenever epidemics happen. Fortunately, every state now has trained disease surveillance and notification officers, both at the local government and at state level. And these groups this cadre of people are people who are supposed to pick up any unusual illness or collection of illnesses that occur and be able to notify to the state and then to the federal lands, because that is where the resources are. Even I don't think there is any state, well, maybe apart from maybe, I don't know, Lagos may have, but in the state, I don't think there is any laboratory where any new disease entity can be properly investigated. So basically, is to collect samples and transmit to these specialized labs where maybe decisions can be taken. Going forward, a lot of, and the stage where we are now, I think the emphasis is on vaccination to address the COVID pandemic. And even at that, you still find that basically the state depends on the federal level and donors. Including donors like the KNCB, which is now doing a 1 year, you said, funded global vax project to help, accelerate vaccine uptake in the states. And so even to train staff, the state still depends on these entities, donors, federal government, to be able to conduct this training, WHO and UNICEF and all that. So it's really a problem that or a challenge, if you may call it that, needs to be addressed for the health sector to become more vibrant at the lower levels. I think Nigeria has to actually address frontally its structural distribution of where resources are, to empower lower level governments, state and local governments, to be able to actually take some initiative, because the way it is now is like, for me, it's like a servant-master relationship. You're always throwing cap in hand to the federal government, to donors, to NGOs for this and that whenever the state has issues. And we are trying to say, and while we were there, it was always a problem. To get resources to do even minimal things is almost impossible, except that assistance comes from health. So it's a problem that is cross-cutting across all health issues, not just the COVID pandemic. And I think we need to look at that as a major challenge that needs to be addressed. Now, in terms of uptake now, because even when we are, the KSTV supporting this uptake, we find that there are still a lot of gaps in terms of mobilization which is an area you think the state would have been able to at least come up with, to mobilize people to come actually assess these vaccines and these other. But even the mobilization, you still find that they are looking for partners who will support mobilization, who will support the training of the health workers to be able to give vaccines and all that and record appropriately. So I think this is the major angle I'm looking at. I have tried to look at these problems, and it's really a long way to go before we can start, except really we restructure such a way that these lower entities will also become vibrant and strong financially. I think I want to stop here. If there are questions, then maybe we can expatiate on some issues. Thank you very much.
Thank you, Dr. John Debe, for this great presentation. And right now we'll go into the question and answer segment. So anyone that has a question, please bring it forward for the panelists to respond to. Thank you.
There's a question on the chart from Professor Ndibe about demographics or the risk factors for COVID comorbidity in Nigeria. And this is apt to my previous comments, because I was asking, where are the studies from Nigeria on the factors that underpin COVID-19 severity? Did it affect the elderly more or the children more? Workers, obese people, or otherwise? Is there no person or institution that is capable of taking up this deeper dive into COVID-19? All we talk about is how we built 2 centers here and 3 centers there, how we trained 5 people here and 20 people there. But there is no granularity, there is no depth. Even at my former institution where I left before, while COVID was raging, we actually wrote about COVID and children with type 1 diabetes, whether there was increased effect during that lockdown. So I agree with his question, and I leave it to the government officials on the panel to please educate us on what were the determinants of COVID severity in Nigeria.
So if I may be allowed to come on board, Chairman. So Professor Omosu, thank you for your statements. First of all, I'll start with a statement that you started off with earlier on, where you said COVID did not touch our country. I hope that doesn't mean that the 3,000 plus people, which is an underestimate of the number of people who died from COVID in Nigeria, were not considered as significant. We know the issue with COVID. There's a significant amount of underestimation of the disease burden in the country, partly because of testing. When it comes to the issue of testing, travel testing has never been free. As far as I'm aware, virtually most countries in the world, you charge for testing. But when it comes to actual COVID testing for the purpose of epidemiology and disease, it's free in Nigeria. Anybody, any center, any lab, public health laboratory or lab that is owned by the state government charging for COVID testing, it's wrong. It means that they're just taking money off people, because those COVID test kits were provided for free to the centers. They were not bought for the purpose of selling. However, for travel testing, I have no problem with travel testing being charged, because travel testing in itself is a private endeavor that people should be charged for. And in any case, there aren't enough resources for government to be paying for free COVID testing for travelers. But having said that, I'm no longer a government official anyway. Going back to your issue of publications, myself and colleagues have published at least 5 papers on our experience with COVID-19 in the country. If you check, you will find either myself or Ibrahim Abubakar, who is currently the dean, a dean of the Faculty of Population Health Sciences in University College London, or a host of other colleagues, including a paper that we wrote where we included some of the members of the Presidential Task Force itself. Our experience is well documented. Even at the moment, we are in the process of resubmitting another paper to be published in a major journal on the differences between the COVID response in Nigeria versus the West versus other parts of the world, such as Southeast Asia. So yes, we know that we have problems in our country. There's no doubt that we have health issues. There's no doubt that the health system is not working. But the advent of the Presidential Task Force, followed by the Presidential Steering Committee, has been a very positive thing for the country. I can stand on my 2 feet and say that the system has benefited from the structured and coordinated way we run the COVID response. Yes, we could have done things differently. And I do agree, if people say maybe the lockdown, for instance, with retrospect, the lockdown had an adverse impact on our economy and could have been done in a different way, yes, but we were trying to avoid people dying unnecessarily of COVID. And in any case, at that time, nobody really knew what the true impact would be. I have colleagues in the National Institute for Medical Research, NIMA, that at the moment we are funding through a major research program with the University of Cambridge, where we are looking into not only the epidemiology of COVID in Nigeria, but drilling down to even the variants that are emerging. Where are they emerging from? What are their susceptibilities? What is the issue with when it comes to the availability of other COVID medications that are currently being used outside the country and their impact? So in summary, what I'm trying to say is, if we make a statement, we really need to look. If we are not sure, this is the purpose of the web, at least to inform people, to let people know what is going on. And where we have weaknesses in the system, such as the current low vaccination coverage, we find a way to deal with it. Thank you.
I may also add, thank you very much, Dr. Sani, to that point. Certainly the purpose of making publication is to use the data. I am personally aware of over 15 papers that have been written, largely guided by the US Centers for Disease Control and the Nigeria Centers for Disease Control through the Africa Epidemiology Network. These papers have been published and they have been presented in international conferences. But for us as a country, the important thing is using the data. Each of the major hospitals that have isolation facilities constantly review their data, and it is based on that data that decisions inform the actions that are taken by Federal Ministry of Health. Every week, I'm aware that there is a review of the case management data by Federal Ministry of Health, presented by all the case managers from all of the tertiary institutions in the country. And this data characterizes who are the people at risk, who are the people who died, who are the people who recovered, how long did it take to recover. All these variables and indices, are things that are followed. And outside that, our academic institutions also are requesting for data to work on it. We have a whole research group that is multidisciplinary, centered within the Ministry of Health, that facilitates research. There are a few little, operational research that are going on regarding attitude of people, to COVID care, the quality of care that they have received, and also the, some of the clinical variables observation. In terms of that. But having said this, let me go back to the issue of why Lagos and Abuja. COVID came, and in epidemic preparedness, knows there is somewhere that is a focus of infection. COVID did not start in Nigeria, and it was largely, our epidemic was driven by international travel. And as we know, Lagos, almost 70% of all the passengers that come to Nigeria go to Lagos. Ebola came to Lagos, and COVID, when it came, it also went to Lagos. And then next after Lagos is Abuja and Kano. And that is why, because these are the gateway, these are the areas where the diseases of international concern kind of travel through, and that's why we strengthen our surveillance system in these areas, and that is why the focus is really there, and the numbers don't lie. The numbers of Lagos are not comparable to the numbers in Yobe State or in Gombe State. So there are reasons, for all of this. Thank you.
Thank you for the response. I think Dr. Ndibe has a question. Please go ahead, Dr. Ndibe.
Let me start my video because I want my face to be seen as I speak. Can you all hear me?
Yes.
Okay, so I'd like to respond to part of the presentation. I think that Dr. Sani Aliyu was just speaking about vaccine uptake. And that's something that I have profound issues with, because in America and elsewhere, people are now being told at some demographic groups to take back, maybe the second booster or the third booster and so on. Nigeria doesn't have the resources to give everybody even one vaccine, one shot. And this is the first time in history, perhaps, where we're administering jabs that do not stop transmission and jabs that are in a lot of ways experimental. This is the first time that the mRNA vaccines have been used on this global scale. There are questions about there being leaky vaccines, which are not effective at stopping. So the goalpost has moved. Initially they said, you take it and you will not have COVID. And then you are told that you take it and you will not have severity of case and so on. So we are now at even the sub-Omicron variants, the sort of more transmissibility, but less lethality. So I'm wondering if vaccination is a proper policy in Nigeria when a lot of people, even in the West, are questioning whether these vaccines were the proper response to a pandemic, which they have been unable to stop. And you look at the world, most of the cases are rising in countries where vaccination has been at the highest rates and so on. So I want to question this idea that an uptake in vaccination is something good for Nigeria. And the other question is that Dr. Babalola from Nigeria has been part of a study which shows efficacy of ivermectin, which is a medication that is widely available. It's off license, and so it can be produced by any pharmaceutical company. I know that there has been some international effort to sort of suppress ivermectin, but you look at those who have had COVID, and more of them are swearing by the efficacy of ivermectin. And where a Nigerian Dr. Babalola has been part of a study that shows its efficacy. I'm wondering if we shouldn't delink from this consensus by the West and perhaps begin to think about what works for us. So I'm going to shut up and listen to your responses. Thank you.
Thank you. If I may come into the issue of vaccination. So there are two purposes at the moment when it comes to COVID vaccine: to reduce the severity of illness and to also reduce the risk of the number of cases overwhelming a health system. The COVID vaccines achieve this. Yes, COVID vaccines will not stop transmission. Yes, COVID-19 will not stop you from having the vaccine, especially beyond 6 months, will not stop you from getting COVID again. But what it will do is that it will stop you from going into intensive care. It will stop you from requiring oxygen. It will stop you from taking over beds that should be used by other patients with malaria and other health conditions. And that's where we are at the moment. I'm part of a group that's currently funding major vaccine initiatives, which are now looking at wholesale vaccines where the vaccine itself that will be produced will not be dependent on variants. But I do agree with you that whatever vaccine that comes in, the likelihood is you will need to have more than one dose in a year. And I think the priority at the moment for Nigeria is to make sure as many people are vaccinated as possible, but more importantly, those that are vulnerable to developing severe illnesses. Because if you have, for instance, if you are immunosuppressed, if you've had a transplant, if you have a badly controlled diabetes, if you have cardiovascular disease and you catch COVID and you do not have the vaccine, it doesn't matter whether it's a Delta variant or the Omicron variant, you're very likely to go onto intensive care. The issue of ivermectin, I'm afraid, has already been resolved. There was a major multi-sector international study that was released a few months ago, and the evidence was very clear. I'm afraid ivermectin does not work. Thank you.
Thank you so much, Professor Liu. I will go ahead and add on to that from my background in clinical research on vaccines. Yes, the vaccines are not a curative, is not a curative option. Rather, it's actually helping with those to keep us actually going into the severe reactive state, and also helping those with comorbidities, keep them actually out of the ICU, as he stated. And there is efficacy. I know that because of when the EUA, when the vaccines were approved for emergency use, it was the Delta variant that was being dealt with. Now we have the Omicron variant, and we're still having more of the subvariants. So it's still actively ongoing, to cover all the variants that are coming up. But the truth is that those that receive the vaccine, from the data available now, there's less severity, although it comes in. So you see more of people with the flu-like symptoms, the cough, and it resolves. Other than we were having more of the SAEs, people dying as against what is obtainable now. So yes, and that is what it is here in the US. But when we talk about the vaccines in Nigeria, my question for the government officials is, how are logistics for what we already have? How are we sure of the stability and the viability of what the people are receiving? And for Dr. Mukhtar, I had a question with those epidemiologists and the clinicians trained. What is the spread against the rural and the urban areas? And knowing that a lot of clinicians and epidemiologists, they really do not, everybody would prefer to be in the city, and that we know, than going to the rural areas. So how are we getting in touch with those at the rural areas? Because yes, the Lagos and Abuja could be the epicenter, but we know that there's a lot of movement, and the way cities are structured, we can have a lot going on at the bottom, that we are actually taking note of. So yeah, we still have to talk. That's where we're coming with the human resources. So let me just leave it there.
Okay, thank you so much, Dr. Obiwan. Let me, because we have to be concerned about time, we have another panel that so what we're going to do now is we are going to take the question from Informa Okafor and then get a summary from Dr. Gladstone on the comment section, and then let them answer it, including including getting Professor Nwosu to respond to the comment on him. Then we go to the second panel. After the second panel, we'll have another question and answer. So, Ifeoma, you can ask your question.
Thank you. Good day, ladies and gentlemen. Ogo, thank you for putting this up. I am currently resident in the States, and I'm a government employee. I work within vital records, health statistics, and during the beginning of the COVID-19, there was, yes, a task force set up, but also what the state government did was to pull people from different departments to be part of that team, not necessarily with a medical background, but to answer questions, take phone calls, enter data into the system. And then for physicians and attorneys to review some of the emails that we end up sending out in response to those citizens or businesses or parastatals, like you guys call it in Nigeria. Do we have any such thing in Nigeria? I know that I personally have, during the process and during all this, I was sending a lot of data to the key people in the presidency. I was sending it to them and I could see certain things that were being used, but it's so they understand that there is a process. And let it not just be that typical, oh, it's Nigeria for you. You guys tried, but Ogo, you know, I lost 2 brothers, my eldest brother and my kid brother to COVID. So it's not an easy thing. And I have suffered it along with my kids. And with the vaccines, and despite the boosters, when you get it, it's not easy. I'm still dealing with it right now. What are you telling the Nigerian community? Thank you.
Okay, thank you, Foma. Thank you so much for that question. I'm seeing more people raising their hands. What we're going to do now, just so that we can, we'll give our panelists opportunity to respond. And then remember there will be another question and answer section after the next part. So that we can get to that. Let me call on Dr. Liu, if you're still there. We'll start with you, then Mukhtar, and then Professor Nwosu, and then Dr. Ndibe. Anybody?
I am sorry to hear about the experience of the last speaker when it comes to COVID. Certainly, COVID is not completely resolved. It's still very much around. But as I said earlier, the goal of vaccination is really to reduce the severity of the illness and to stop those that have other comorbidities from filling our intensive care units and possibly dying from the disease condition. There's still a lot of research going on in terms of coming up with much better vaccines that would have greater efficacy against a range of variants. But at the moment, that work is still in the sort of basic science stage. But I'll still keep on saying that in Africa, and especially in Nigeria, we'll be doing ourselves a disservice if we say that we are going down the route of not taking vaccination. I really hope that's not going to happen, because inevitably it will affect our health system. We have just seen another wave of COVID that's come and gone. Nigeria has been lucky partly because of the nature of the demography. The fact that we have a significant youth board. COVID, even for those that are not vaccinated but are relatively young, is very likely to be mild. But that doesn't mean that we won't have people dying from the disease. In terms of research, as I said, I'm not a government official, but I know a lot of resources are going into research to do with COVID, both at NIMA and some of our universities and teaching hospitals. That research is feeding into the current data that is coming through with regards to the efficacy of treatments. But whatever treatment we support in Nigeria, it's either a patient goes on a drug based on a clinical trial if that drug is not authorized for use, or we use drugs that have already got a very strong evidence base. Modern medicine is not the same as traditional medicine. I'm afraid it's not like going to your local babalawo. So if I'm giving you paracetamol as a physician, I need to be very certain that paracetamol will work. If I think it will work, then I will need to put you through a clinical trial where it will be measured and the efficacy will come from. So I'll stop here, but I'm sure Dr. Mukhtar will have responses with regards to some of the issues, especially the demand for vaccination and the logistics associated with vaccines. But working with the Africa Union Commission, we know that Africa is doing itself a great disservice if we continue to say that we will not take these vaccines, because the world will just turn back and say, well, there's no demand for the vaccines and we will use it elsewhere. Thank you.
Okay, so let me just quickly add that there are a lot of ongoing efforts to make sure that we increase the vaccination coverage. And we have seen the data on state-by-state basis, on the uptake. But still, it has not reached the level that we'll say we are comfortable. And this is not surprising, because we know the attitude of Nigerians, particularly when they see that we have removed all the restrictions regarding COVID, when they see that people are not falling ill, when they see that people are not dying in the hospitals, and people, generally are lethargic about, coming out to take the vaccines. We also have, the booster program. I think Professor Nwosu asked about it. The booster doses are available. People are taking, their third booster and even additional ones, because we know, based on evidence now, that the vaccines wanes out. Getting into the rural communities, really, that is a challenge. Even though we have the Johnson & Johnson, which doesn't require much of the cold storage chain, but we have seen the efforts made by specific, leadership of states, where they mandated, the local governments to deliver on the vaccine coverage. What we do from the center at the national level is we insist that anyone who is traveling out of Nigeria must show evidence of vaccination. And this has paid a lot, because during the last Hajj program, all the pilgrims that left Nigeria, is about 40,000, had to be vaccinated. And when you are coming into Nigeria, you also need to show the evidence that you have received your vaccination. If you don't, then you will be required to test multiple times, in accordance with our protocol. So this is a kind of, a disincentive that we've created, so that people will not be encouraged to take the vaccine. As you are aware, it is not mandatory. I'm not sure any country has made it mandatory yet, but it's about the public knowledge and public awareness to make sure that people take up that. There was a question about the training and capacity building, about the spread. Certainly, the epidemic preparedness is an ongoing thing. Long before COVID, Nigeria we started our field epidemiology and training program in 2008. And we've been training, people, initially medical doctors, epidemiologists, then veterinary doctors, because there is the link between the animal disease and human. And then we're also training laboratory scientists on it. These are the training that leads to, award of a master's degree program. But underneath that also, we've had several mid-level and low-level training, which is targeted at local government, particularly the IDSR officers, the ones we call the surveillance officers in the states, and also in the local governments. So now all the local governments have dedicated surveillance focal persons, and these people have been trained in terms of reporting of the disease. They have an electronic means of, if they see a patient, if they see a cholera outbreak, they will be able to recognize, and they should be able to report to the state, and the state will report to the center. If there's a Lassa fever outbreak, they should be able to do that. And then there will be the response angle that will be coordinated between the state and the federal government. So these are ongoing efforts. We are not still satisfied with the level of training. As you know, it's a continuous effort. I think someone mentioned about the dysfunctional nature of the health system, but we are working within what is available now. We know that the health force is concentrated in the teaching hospitals for obvious reasons, because they are paid by federal government. The pay is better. If you're a consultant, what you earn in the federal teaching hospital is twice or more than what you earn if you're working, in a state hospital. There is generally disincentive for people to work in general hospitals, or for other health workers to go to primary healthcare centers. These are the areas that we need to strengthen through our basic healthcare provision fund, which we just started implementing, and also the universal health coverage, so that we make deliberate efforts to incentivize healthcare professionals to participate and work in lower health hospitals. Thank you.
Professor Nwosu, please, if you want.
Thank you again for allowing me to speak. Again, my vantage point is that of the Nigerian youth and the Nigerian the poor people. Let me put it that way, the people with no voices. So my question is this, again, when we talked about research, I heard there were some papers coming out of Nigeria. I'm happy to hear that. I also want to see if these papers can be shared with the audience, or at least sent to some of us. I want to see whether these papers are comparative epidemiological research, because I think they're comparing how Nigeria fought COVID compared to how it was done in the West. But why are we not looking at the real thing, the molecular research of how COVID impacted Nigerians? Two, even the vaccine that are being shipped to Nigeria, has there been any study looking at their immunogenicity? Okay, and then how long does it last? Are we just taking data from Europe and America and then basically using that as the Nigerian experience? Now, there were a lot of funds. We always say, oh, Nigeria doesn't have money. There were a lot of funds raised at the beginning of this pandemic by some Nigerians who donated billions of naira. What happened to that money? Okay. We talk about capacity building. Here in the US, at least I remember in my hospital, what they did was redeployment. One, when they were overwhelmed in the ICU and the wards, they went to a stadium and opened up clinics there. And then even those of us who had no training in internal medicine, who were asked to either volunteer as internists or laboratory technicians or whatever, just to make sure that things are moving. So you don't say, I'm building capacity every day, okay? We knew back, does anyone remember Health for All by year 2000 or I don't remember when Ransom Kuti was the health minister. Health for All by year 2000 or something. I think I'm getting the date wrong, but we're supposed to be healthy in Nigeria many decades ago. Why are we still building capacity? Okay. So, and then finally, the comment by Dr. Aliyu that when I said COVID blew past Africa, I wasn't making light of the 3,000 deaths that were recorded. However, if you look at the 3,000 deaths, can we please have data proving that they were actually due to COVID? That's one. I'm not saying they are not due to COVID, but this is where data collection is key. And then, of all the other deaths in Nigeria, do we have evidence that most of them were not due to COVID? Again, this is importance of data collection. So we may have underestimated what happened in Nigeria. Maybe 100,000 people died, but we don't know. So data collection is not something you do only in Lagos and Abuja. You have to set up nationwide data collection, like one of the speakers who lost relatives to COVID, sorry to hear that, said. These centers will have to feed data to the federal government. The over-centralization of healthcare in Nigeria is not working. There has to be regional decentralization. Thank you.
Dr. Gladstone, I wrote, this is just a summary. He was wondering, why did we insist on lockdown for as long as we did, even though that it was obvious that the elderly are the most at risk. And our population, if you look at the pyramid of our population, that is only 2.3% of Nigeria's population, that is over 65%. He has another question about how we have practiced safe distancing, considering that 10 people live in one room. And I know when I called him about this conference, he was one of those people I invited personally and I wanted him to come. He mentioned the issue of not knowing how many people are born in Nigeria and how people die every day. So what are we doing to deal with it? So I'll give the last minute to our panelists. Anybody to weigh in on this, and then we'll go to the next thing.
So maybe I can answer the issue of why did we lock down for as long as we could, as we did, really. So I remember at the time that we locked down, people didn't really know what COVID was all about. People really didn't know what COVID was all about. People were frightened and afraid. Nigeria was one of the last countries among the big countries to actually go into lockdown. And we didn't lock down the entire country. It was Lagos, Abuja, and 3 other states. By 5 weeks, a lot of the information that was coming through was very clear that people were having difficulty even getting food, etc. And as I said earlier on in my talk, there are things that right now, if we were to come into that same situation, we probably would have done it very differently because we know the effect that COVID has. But at the time, it wasn't very obvious. It's just like now, if we have Ebola, for instance, or just like we have the viral hemorrhagic fever in Ghana, if it comes into the country and it's reported in Kano, what do you think the authorities would do? They would sit down and say, let's wait and see who is affected more severely before we take action? No. I'm afraid when it comes to public health emergencies and management, it's better you take a decision and then review a decision afterwards than to sit down and say, let's wait and see. We do not have that luxury, I'm afraid. Thank you.
All right, thank you so much, Dr. Leo. Dr. Mukhtar, you want to weigh in?
Yes, thank you. Let me just add on maybe the question that was asked about confirming deaths. Certainly the numbers that have been reported, these are the numbers that have actually been confirmed. It is possible that that number is an underestimate, but the numbers that have been confirmed, actually the people died and they had COVID. We have to link all of that before they are classified as COVID-19 deaths. Secondly, we had a case in Kano in April 2000 where people were reporting high mortality. And that was the point when we mentioned there was a lot of apprehension. The healthcare workers were not sensitized properly. There was not enough infection prevention control in the facilities. A new lab that we set up in Kano, all of the workers in the lab came down with COVID infection because they didn't do the IPC properly. And that's why the issue of capacity building is very important. It's a continuous process. You cannot stop learning. You cannot stop improving. You have to do that. So in Kano, what we did that time, there was an investigation. We had a verbal autopsy and mortality review. A whole team was sent of epidemiologists to go and investigate that sudden death. They interviewed people in the graveyards. They observed number of people coming for funerals, reviewed the data from some of this phenomena, and they wrote their report. They came to the conclusion. So there were a lot of things that were done, perhaps maybe were not highlighted. But again, as Dr. Sani mentioned, there are things that have happened which we could have done differently now, having the knowledge that we have today about COVID-19. And it's the same thing about any other public health emergency. When you are dealing with a disease that is previously not known, it is better to err on the side of caution and make sure that you prevent infection, you prevent deaths, you prevent mortality as much as you can. And I think the issue of lockdown, it's just in line with that. But later on, and the lockdown was not really long, and it was just in a few places. There are simulation exercises that are constantly being conducted, maybe in Nigeria and also in collaboration with other countries about these pathogens of unknown origin. And we always anticipate the worst. So whenever you have any new case, you anticipate that it's going to be the worst, and you take the prevention that you need to make sure that you contain the spread within the shortest possible time. Thank you very much, Rudolf.
Okay. All right. So who else? Dr. Nwosu, Professor Nwosu, do you have something to say? We are rounding up. We have to go to the next panel. Oh, go ahead.
Dr. Rudolf, before you go, I'm sorry, Dr. Nwosu, before you go ahead, Dr. Rudolf, there's a question with regards to, that would be for Dr. Mukhtar. There's regarding the J&J vaccine he mentioned. And the question was about the criteria for given this vaccines to, because he mentioned that this is the one that is more stable with regards to the logistics. And there is actually this issue with a side effect, a common side effect of thrombotic effects in risk factors, a thrombotic risk in females, actually males and females from 18 and above, and more in females from 30 to 49 years of age. So what do they take into cognizance this side effect? Because this is fatal that one out of 7 cases results to death. So now that this is what is more available to the population in Nigeria, and look at the demographics involved, are they taking this into cognizance? And what are they doing?
The National Primary Healthcare Development Agency, which is responsible for driving the vaccines, has decided to prioritize the use of J&J vaccine for difficult to reach population. Because, as we earlier understood, that J&J needed just a single shot. Even though now there is some review about also having an additional booster dose. And people are trained about also reporting adverse drug events. And every day we also receive data from the mildest symptoms, to the severe symptoms that have been reported. I'm afraid over this last 6 months or 8 months, since J&J has been administered in the country, we have not recorded any mortality related, to other administration or adverse drug reaction, from the vaccine itself. So, but the important thing is set up the process, set up the system. For every drug, for every vaccine, we know that there are side effects, and we know that there are people who will not react normally. There is always that small proportion, that can have an untoward effect from the vaccine. So the important thing is setting up the system, make sure that the data is collected, and there is a quick response to that. I believe the NPHCD and the states are reporting on all of this on a daily basis. But so far, I'm not aware of any thromboembotic fatal effect on any of the people that received J&J in Nigeria.
All right, thank you so much, Professor Nwosu. You have.
Thank you again. Happy to come back. So again, I have 4 questions for Dr. Mohammed because, I have to really speak on behalf of the Nigerian people. My first question is, what happened to all those funds that were donated by Nigerians at the beginning of the pandemic? Then number 2, why is it that the health minister, Nigeria, does not visit the teaching hospitals to understand what's going on there and to see for himself the dereliction of facilities in these places? I know because some of us actually fund some of these teaching hospitals in one way or the other. And then number 3, do we have adequate funds to continue to fight COVID-19 pandemic and whatever else is coming down the pike in Nigeria? Thank you.
Okay, we are really out of time for this panel. I would like briefly for Dr. Liu and Dr. Mukhtar to respond. If Dr. Ndibe wants to say something, please let me know, and let's make sure that you are still with us and you're part of this conversation. Then after that, we have to go to the next panel. We are so much behind. Go ahead, Dr.
Okay,
Mukhtar.
so let me just start. I think the questions are very straightforward, even though I got 3 out of the 4. What happened to the funds? The funds, as Dr. Aliu mentioned, were donated by the private sector. The fund was not spent by federal government, but the private sector provided a plan on how to utilize these resources. You are aware of the isolation centers they set up in the stadia in Lagos, in Kano, and 6 other states. You are aware of the procurement that they made of PPEs and other materials. You are aware of the oxygen supply that they also facilitated, in a lot of the hospitals. I'm not aware of this, what you mentioned, that Minister of Health not going to the teaching hospitals. I know last week I met him in a meeting with the CMDs of all the teaching hospitals. So, and I know that he was in Maiduguri to commission, and in Yobe also to commission one of the facilities there. So I think certainly that is not correct to say that. On whether we have adequate funds, yes, there is the goodwill. The system is there to mobilize resources, but certainly there is not enough funds. No one will say that we have all it takes, all the resources that you require to be able to face future pandemics. But the mechanisms that have been set in place now can be utilized to mobilize resources, not only just financial resources, but also human resource and technical resource that will be required. Thank you.
Okay, thank you so much.
So if I may just say something about the teaching hospitals, because I know Professor Ngosi is worried about the teaching hospitals, and it's a trend that is very similar to those of us that work in tertiary centers. The problem with the health system in Nigeria is actually not the teaching hospitals, it's the primary healthcare centers. The average primary healthcare center is not well resourced, and that's why people with malaria and other minor disease conditions go to the teaching hospitals and flood the teaching hospitals and overload them. The problem is not with the teaching hospitals. Secondly, the teaching hospitals, to be run properly, they need to be funded adequately. That resource really should go to the primary healthcare and the secondary healthcare centers first. And we make sure that we sort that out before going into specialist care. Thank you.
All right, thank you so much. Dr. Ndibe, are you still there? And do you have a comment?
Yeah.
Okay.
Yeah.
Okay.
Yes, I'm there.
Okay.
Just to reiterate what I think what the two last speakers have said actually comes to confirm what I said during my presentation. The resources are up there, even though they are still not enough. But you find that down where most of those resources will come, which if they are properly funded, will actually place less pressure on the tertiary center. The resources are not there. Most of our PhCs, people don't want to go there because they are poorly resourced, poor staffing, poor equipment, and so that makes, and the secondary health centers too. So it makes a lot of people move towards the tertiary centers, and then you find that even what the so-called lot of resources that you put there is still not enough for them to handle what. So we need to re-engineer the system in such a way that we send more resources to where the problems are, which are primary health centers and secondary health centers. In terms of resource use, in Nigeria, because of our antecedents, people always believe that resources are misused, and in some cases, yes, but I don't believe that all of it. A lot of things we actually provided during this pandemic from the private sector, from the federal government, and a lot of them came down to the states and to the PHC. So we are doing something, but definitely it's still a long haul to go. Thank you.